Well, hello, my name is Dr. Dan Lozier, and today we're going to be completing the trilogy of videos on the respiratory system and on the management of patients who have respiratory disorders. I'm excited, so let's get started. We'll begin today talking about pulmonary embolism. Sometimes you'll see it as pulmonary emboli. Sometimes you'll just see the initials capitalized P and E. Pulmonary emboli falls under the umbrella term of venous thromboembolism. So let's look at that right here, venous thromboembolism. And look, if you divide the word up, thrombo and embolism. So the thrombo would be covering deep vein thrombosis. The pulmonary emboli begin as a thrombosis, and once they break free, they become an emboli. If it happens to be in the deep veins, typically it's going to be in the deep veins of the legs, below the not below the knee, which is what most people suspect, but it's actually above the knee. It is rare, or I'll say less common, significantly less common, for a thrombus to break free from below the knee, travel up and over the knee joint, and get into the central vascular system. So again, most of those would be above the knee, kind of in your thigh to groin region. Look at this number. I know it's a broad range, but somewhere between 350,000 and 900,000 venous thromboembolisms occur every year, with 100,000 deaths. That's a lot of deaths. I have personal relations that have suffered a pulmonary emboli and have died. My uncle's first wife broke her leg, had a compound fracture, had it surgically repaired, was in the hospital, and the next day in the hospital she threw a emboli, and she died from a pulmonary emboli. We had a nursing student who was 2 weeks from graduation, fairly young. She had young kids in elementary school. She did have some risk factors, but she was driving to pick up her children from, I believe, she was leaving after clinical from the elementary school, and she suffered a massive pulmonary emboli and just kind of drifted all over to the side of the road. It just so happened that there was a nurse and then a physician in the two cars behind her, but they weren't able to save her at that point. My cousin was going in for a knee replacement. I remember she called me from Florida the night before and said, hey, I'm looking forward to having this surgery, and I'll be able to play golf again. And wished her well with that surgery. And she actually died on the table while performing the knee replacement. I myself, a little over a year ago, ruptured my Achilles tendon, and subsequent to the surgery, started developing unusual pain, not in the Achilles area, but in my calf region. And it turned out that I had 5 vessels that were occluded by a venous thromboembolism. Fortunately, they were all below the knee, and was started on anticoagulants for a 3-month period of time. So clearly in this 350 to 900,000, you are going to find people that who have experienced that. Somewhat of a high incidence of individuals who have a pulmonary emboli or have a deep vein thrombosis and have a recurrence within 5 years, and the rate could be as high as 30%, which is nearly 1 out of every 3. Now, those are the individuals that have predominating risk factors for that, more than the individual who's just suffered trauma like I had done with my rupture of the Achilles tendon. They have underlying medical conditions that predispose them to recurrent pulmonary emboli, or at least venous thromboembolism. Approximately 50% of all new cases occur during the hospital stay or less than 90 days after the patient has been discharged. Similar to when we had a term for like healthcare associated pneumonia, we have a term which is healthcare associated or hospital associated venous thromboembolism. Look at all these risk factors. No, you do not have to know all of these risk factors. In fact, you probably don't have to know any of these risk factors by memorization. But what I want you to see is that look at the number of risk factors. That's why we have such a high number of incidents of VTE, 300,000 and 900,000. Hip or leg fracture. That was my wife. My uncle's first wife. Hip or knee replacement. That was my cousin. Major surgery, major trauma, that would fit in me with a ruptured Achilles tendon is considered to be a significant injury. Spinal cord injury patients. Central venous catheter lines have to be careful as nurses that we're not introducing air through a PICC line or a central venous catheter, because that air is going to go directly into the central vasculature. Heart failure, respiratory failure, cancers, and then again, the older you are, the higher risk for life that you are. Greater than 65 years of age is another predisposing risk factor for VTE. Continuing with risk factors for your VTE. These are weaker risk factors, but these are risk factors still the same. Prolonged bed rest and immobility. That's why we get our patients up and moving in the hospital as soon as possible. Age, we talked about that. Obesity, we've talked about that over and over again, and it's in epidemic proportions. Pregnancy and varicose veins. There I go again with my coughs when I talk about the respiratory system. I don't know, psychosomatic, I guess. Pulmonary emboli, pulmonary embolism. When we have that thrombus, let's say that we have a blood clot, and the blood clot, deep vein thrombosis above the knee, and that breaks free. Well, where's it going to go when it breaks free from the thigh region? Well, it's going to eventually find its way into the inferior vena cava. It's going to travel up now in the central system, inferior vena cava, and it's going to then dump into the right atrium through the tricuspid valve to the right ventricle, from the right ventricle through the pulmonary artery. It's going to go to the lungs, and that's where the problem is, that as the clot gets further and further along in the pulmonary vasculature, eventually arterial vasculature, it's going to get stuck, and everything that is distal to that emboli is not going to get perfused, so that will determine the degree of the infarction of the emboli. So here's what we're looking at here. So deep veins of the legs, we have an emboli. That emboli breaks free, it travels up, we're traveling up into the inferior vena cava, and then it dumps itself into the heart, and from the heart it goes into the lungs. Now this is the pictorial here of the lungs, and you can see that as the emboli travels down the arterial vasculature of the lungs, eventually, depending upon the size of the clot, it's going to get lodged. So it's going to get lodged. That's what this is showing right here. So everything that is distal to that emboli is not going to be perfused. And in this situation, there's still a significant amount of lung that is not going to be perfused, lack of oxygen. Eventually, the cells and tissues are going to die, and you have an infarction. Clinical signs and symptoms, I do want you to know the classic triad for a patient with a pulmonary emboli. Again, that doesn't mean that in every time, in every circumstance, at all times, this is what the patient is going to manifest, but these just tend to be the three clinical manifestations that seem to come together fairly often. Chest pain, dyspnea, and hemoptysis. So good thing to know. Chest pain, we certainly recognize what that is. Dyspnea is difficulty breathing. Hemoptysis is blood-tinged sputum. Hemoptysis, blood-tinged sputum. Do not confuse that with hematemesis. Hematemesis is blood in the emesis. Hemoptysis is blood in the sputum, which would make sense since it's coming from the lungs and not coming from the gastric, the GI system. Other symptoms, clinical manifestations, anxiety. The patients oftentimes will report when they're having a pulmonary emboli that there's this incredible, overwhelming anxiety to the point where it is like this fear of impending doom, like the world is coming to an end immediately. That level of fear and anxiety. Dyspnea, we talked about tachypnea, which makes sense, as particularly as the patient gets hypoxic. They say that tachypnea is the most common clinical manifestations, tachycardia, and certainly resulting eventually, just depending upon the size of the infarction, with hypoxemia. When we looked at diagnostic procedures early on, we said that the hallmark go-to diagnostic study to definitively confirm that a patient has a pulmonary emboli is a spiral CAT scan, a spiral CT. In the event, however, that the patient might have an allergy to the contrast, we go to the previous gold standard, which is the VQ perfusion scan. You'll remember that that's nuclear medicine. It's 2 steps. We're trying to determine, since this patient is hypoxic, is it a perfusion problem, so that related to the cardiovascular system, or is it a respiratory problem? And so that's when we have your ventilatory versus perfusion scan. The patient will actually breathe in a radioactive gas like a xenon, and they'll look to see if there's diffusion, to see if it's a problem with the lungs. And then there's also a dye or contrast that they'll put in the vasculature, and they'll look and see how the pulmonary arterial vessels are perfusing, and so when they're able to see the pulmonary arterial vessels and that dye comes through, and all of a sudden there's a blockage, that means that everything distal to here is not getting perfused. D-dimer is a blood test. D-dimer is a blood test, and it picks up an abnormal amount of coagulation factors in the blood. So obviously, if you have a large coagulation, such as a pulmonary emboli, your D-dimer, in theory, will be increased. The problem with the D-dimer is that it is not a highly specific or sensitive test. And in fact, in 50% of the cases where the patient has a pulmonary emboli, the D-dimer is still within the normal range. So that's why this is our definitive diagnosis here. This might be a differential diagnosis, but this is the old standard, but currently the gold standard currently today for diagnosing a patient with a pulmonary emboli is a spiral CT scan. Collaboratively, the patient obviously is having an infarction as a result of a pulmonary emboli. The patient is going to be hypoxic and hypoxemic, so we're going to make sure that we give the patient supplemental oxygen. If we catch, we being the healthcare community again, if we catch the clot early onset from the time of symptoms to they get to the hospital, sometimes they are able to go in and actually introduce a fibrinolytic, which they're able to do intravenously. A thrombolytic or fibrinolytic will actually dissolve the clot. TPA, tissue plasminogen activator, is an example of a thrombolytic. Streptokinase is an example. So again, that will dissolve the clot. And that is different from a patient who is receiving anticoagulant. Anticoagulation therapy does not dissolve the clot. Anticoagulants prevent the existing clot from getting bigger and subsequent clots from forming. So some of the old familiars are warfarin, which is Coumadin, Lovenox, which is a low molecular weight heparin, and then heparin itself. Just a reminder, warfarin, what do we monitor on a patient with Coumadin or warfarin? The PT and the INR. What do we monitor for a patient on Lovenox? Nothing. We don't have to monitor it. Patient that is on, for example, a heparin drip, we're going to monitor the APTT on that patient. Antidote to too much heparin is we'll give protamine sulfate. Antidote to a patient who's received too much Coumadin is going to be vitamin K. IVC filter. Let's look at what that's. Inferior vena cava filter. I'd mentioned that the deep veins is where your thrombus is often going to form. It's going to break free, and then it's going to find its way up into the inferior vena cava. This is an interesting device, an IVC filter. The first one was by Greenfield, so it's also known as the Greenfield filter. So that is placed by catheter, and this little funnel here is placed. It looks like an umbrella or a funnel, and you see that there's little holes that are in here that are strategically placed. So the blood can flow through the holes, but the holes are small enough that a clot that is of sufficient size to cause damage, if it reaches to the lungs, will get trapped in there. And that's an IVC filter, which stands for inferior vena cava filter. Chronic lung diseases. Now, for chronic lung diseases, we'll be talking about asthma. We'll be talking about COPD, chronic obstructive pulmonary disease. So let's go ahead and get started. So asthma, we will talk about, and you're also going to learn about asthma in probably a little more detail when we talk about pediatrics, but we will touch on it some in this video. And then these two lung diseases, chronic bronchitis and emphysema, they fall under the umbrella term of COPD, which is chronic obstructive pulmonary disease. So if you're asked what two diseases fall under the umbrella category COPD, it's chronic bronchitis and emphysema. Asthma affects 25 million Americans, so quite a few people. Most of us will know one or several individuals that has asthma. This is something I want you to note. There's still close to 3,000 deaths every year from asthma, and we'll talk about how that happens and why that happens. Okie doke. Definitions. I like my definitions. So asthma is a chronic inflammatory disorder of the airways that is reversible. So if you wanted to even add that to the end here of the definition, asthma is a chronic inflammatory disorder of the airways that is reversible. Why am I throwing that in there? Well, in a couple slides when we talk about COPD, COPD is also a chronic inflammatory disorder of the airways, but it is irreversible. Irreversible. So in asthma, there's a hyper responsiveness of the airways. You and I, if we come in contact with a noxious gas, sometimes we go outside and it's frigid cold, maybe hovering around 0 or below, and we have that immediate spasm. We want our airways to react. The problem is with asthma is that it is a hyper responsiveness and can be a chronic hyper responsiveness. So you have chronic bronchoconstriction, chronic airway edema, increase in mucus secretion. The concern for a chronic inflammatory response is that those anatomical structures that are continually and chronically exposed to the inflammatory response, eventually the cells and tissues are going to break down because of that inflammation. When they begin to break down, then you obviously are going to lose or impair the functionality of that particular organ. And so when the cells and tissues begin to break down, that is called airway remodeling. And we'll see that also in COPD. So airway remodeling is structural changes in a negative way that happen because of the breakdown in the integrity of the cells and the tissues after exposure, chronic exposure to the inflammatory response. So this airway remodeling is a negative. This isn't Chip and Joanna Gaines here on Home and Garden. That's a negative. There are a variety of different triggers for Asthma, the most common trigger that triggers this hyper responsiveness or this chronic inflammatory response of the airways are allergens or things that the patients are allergic to. There is such a thing as exercise-induced asthma, GERD, perfumes, respiratory tract infections, but the number one trigger are allergens or things that the patient is allergic to. Three most common symptoms, good slide to know, three most common symptoms of asthma are cough, dyspnea, and wheezing. And the wheezing is an expiratory wheeze, not an inspiratory wheeze. It is an expiratory wheeze. Um, where these are the three most common symptoms of asthma, it's important for you to note and to realize that absence of wheezing may not be a good sign. The patient could actually be in a very severe asthma exacerbation, and the airways are so closed and constricted that we're not even having enough air movement to pick up a wheeze. So the absence of a wheeze does not indicate the patient is not having an asthmatic response. I saw this quite frequently when I worked in the emergency room at Children's Hospital. Mom would say their little one has asthma, and they're just puffing away. They got costal retractions, substernal retractions, nasal flaring, and you listen to them and you're not hearing any wheezes, but they're breathing at 30 breaths per minute. Those are an emergent situation where we would rush those patients back and begin treatment to reverse that bronchoconstriction. And we would give handheld nebulizers, aerosol nebulizers, albuterol nebulizers. And after about 15 minutes, you're never so glad to hear wheezes because that means that the airways are opening up and we're getting some air movement through the patient. Okay, patients that have asthma, there's probably nothing more scary than not being able to catch your breath. So certainly with a significant flare-up in asthma, that patient is going to feel increasingly anxious as they can't get catch their breath. Clinical manifestations. They said that the symptoms could be a rapid onset or could progress gradually over several days. But here's what's happening. We're talking about a chronic inflammatory response of the airways. What is that inflammatory response? Well, number one, the bronchioles are encased in smooth muscle. They're wrapped in smooth muscle. So that smooth muscle will constrict. That's called bronchoconstriction. We talked about that. That's how the bronchioles differ from the bronchi. They have smooth muscle, and in exposure to something that the body perceives as negative to the airway and want to block it off, you'll have bronchoconstriction. That's part of the inflammatory response. You'll have edema, so you'll have an increase in fluid and blood that is going to the area as part of the inflammatory response. And then you'll have an increase in mucus production. So normal lumen right here, this nice smooth open airway. Here's a constricted airway that's also edematous with increased mucus. And now look at how small the airway is. And so that's where you're going to hear your expiratory wheezes as the air tries to push out of the patient on exhalation. Likewise, the expiratory phase may be prolonged. Remember, inspiration is an active process that's controlled by the respiratory center of the brain. Exhalation is just a passive process where the chest wall goes back to its normal position. Your diaphragm goes back to the normal position. Your lungs go back to the normal position. Well, it could be prolonged because we have decreased compliance. Remember, we've got diseased, inflamed lungs and airways, so it's going to take longer for the air to get out. So a normal inhalation and exhalation cycle is equal, meaning inhalation, exhalation, equal time. Inhalation and exhalation take about the same amount of time. In asthma, you could have a prolonged expiration. It could be prolonged 2 to 3 times longer than the inspiratory. What might that look like? Okay, So you see that there's not only the wheezing, in that case there was audible wheezing, but the expiratory phase was probably close to 3 times longer than the inspiratory phase. Complications of asthma. We said that there are 2,500 approximately, so a little under 3,000 people every year that die of asthma. Many die from what we call status asthmaticus. Status asthmaticus is a situation where a patient that has asthma normally is going to know what to do when they have an asthmatic flare-up, and they're going to be able to move to that next level of pharmacologic interventions. But for whatever reason, this time their medications aren't working. The next course of action isn't working. In fact, it's progressively getting worse. And in many of those situations, as it progressively gets worse, particularly if that patient is at home by themselves, lack of oxygen is going to affect the brain. It's going to cause altered mental status. That patient's not going to know to call the squad and get help. And so that contributes a lot to this 2,500 individuals that die from asthma every year. Okay, medication management. So yes, good slide to know. The next couple of slides are good slides to know. And the good news is that you're going to see some of these same slides, the same medications when we talk about COPD. So if you understand the medications that we're talking about in asthma, you're going to understand them when we talk about them with COPD. There are long-term control medications that's to give the patient in order to help decrease the number of asthmatic attacks that they have. So that's more of a prevention and a maintenance. And so those are Ceravent would be a good example. Quick relief medications, on the other hand, are not to prevent asthmatic flare-ups or to maintain stability, but that's when a patient is having an asthma attack. And that's quick relief medicines. We call that rescue medicines sometimes, short-acting medicines. We need to reverse the bronchoconstriction. We need to reverse the increase in mucus production. And Proventil, HFA, is a great example. That also, in Ventolin, they fall under kind of the category of albuterol. Albuterol. All right, albuterol. So you could go ahead and write that in here next to it. So those are quick relief or rescue medications when the patient is experiencing an asthmatic flare-up. 3 types of bronchodilators. Beta-adrenergic agonists, methylxanthines, and anticholinergics. So good slide to know here, be able to differentiate what medications are bronchodilators versus what medications are anti-inflammatory medication. Some are combination, but know the difference between these 2 slides. There are beta cells that are in the heart as well as in the respiratory system. The beta adrenergic agonist. An agonist means that you want those beta receptor sites to be stimulated. Antagonist is that you want to block, like in a beta blocker, you want to block the receptor sites of the beta cells. In this situation, a beta agonist is that you want that medication to actually reach the beta receptor sites. The short-acting, again, rescue medications, here we go again, albuterol, Ventolin, Proventil, HFA are the examples of short-acting. Long-acting beta-adrenergic agonist is Ceravent. That's your long-term or your maintenance. So if you're asked on a question, that your patient needs to be able to recognize what medications to give when they're having an asthmatic flare-up versus what medications they're going to give themselves when they just want to have long-term maintenance or prevention of asthmatic flare-ups. Methylxanthines, gosh, we just saw this in the hospital earlier this semester, in the first half of this semester. Good term to know. Methylxanthines are second-line medications. These are what we used to give our patients. I told you about the little guys that would be having an asthmatic flare-up, and we bring them right back in the emergency, right back to a room, and we would immediately start them on an aminophylline drip. And so again, that might not be the first thing that they do in today's day and age. But methylxanthines are also, they're bronchodilators. Theophylline and aminophylline are bronchodilators that fall under methylxanthines. Yes, you have to know that. Yes, you have to know these as well. Be able to recognize which one is rescue medication and which one is long-acting medication for prevention and management of asthma. The third one is anticholinergic. We'll be talking about the cholinergic response when we get to our cardiovascular system. Remember that there is the autonomic nervous system. It's made up of the sympathetic nervous system, which is your fight or flight, and parasympathetic nervous system. Here we're talking about stimulation of the parasympathetic nervous system, which causes bronchoconstriction. Why, when we're have big meals and the blood is being diverted to the stomach for nutrition and breakdown of the foods, and we're having tissue maintenance and repair with the parasympathetic, that we also have bronchoconstriction. I don't know. I guess we'll have to ask God one day. Okay, this slide is anti-inflammatory. The other slide was bronchodilator. Don't get them confused. Steroids, right away, we're going to have our corticosteroids. Steroids just block the entire inflammatory response. Leukotriene modifiers. Leukotriene is a substance that is released when you have your inflammatory response. Brief review of the inflammatory response: that you have your initial exposure. Let's say you have exposure to dust mites. Well, your body's going to build up antibodies to dust mites. Secondary exposure is going to cause the patient to have a reaction. So those antibodies that are built up, your IgE antibodies, they're going to get released. They're going to find these cells in the body, which are called mast cells. They're in the basement membrane of the respiratory system. The IgE is going to find a receptor site on the mast cell, and the IgE is going to bind to that mast cell receptor site. When that happens, that causes, actually, it will cause the mast cell to membrane to degranulate. When the mast cell degranulates, everything that's on the inside is going to go to the outside of the mast cell. And what's on the inside are prostaglandins, histamines, and leukotrienes. And it's the histamines and the leukotrienes, prostaglandins, that cause all the nastiness of the inflammatory response, which is the constriction, increase in blood supply to the area, increase in mucus production. So a leukotriene modifier, example would be Singulair. It's going to modify IgE, the antibody, so that it can't bind to the mast cell. If it can't bind to the mast cell won't degranulate. If the mast cell doesn't degranulate, those powerful inflammatory mediators on the inside aren't going to escape to the outside, like leukotriene, histamine, and prostaglandin. So we've just stopped it by giving a leukotriene modifier. We've stopped it by giving an antibody to the IgE, which is going to prevent IgE from binding to the mast cell receptor sites and keep the mast cell intact. In a little while, we're also going to talk about a medication that stabilizes the mast cell membrane. It stabilizes it, it reinforces it. So even though you have exposure to dust mites, even though IgE is released, even though IgE binds to the mast cell receptor sites, that particular medication that we'll be showing you is going to reinforce the mast cell so it doesn't degranulate, and so it's going to keep what's on the inside, and we've just stopped our inflammatory response. In asthma, correct administration of the drugs is a major factor, it says. How successful we are. And both long-term and short-acting. Correct management of long-term medications is going to decrease the number of asthma exacerbations, or maybe even the severity of asthma exacerbations that the patient's going to experience. Patient needs to be able to understand when they apply their albuterol-type medications for short-acting when they're having an exacerbation of their asthma. When we're giving medications, inhalation is preferred versus giving a patient a PO medication or giving a patient a IV medication. PO and IV medications, whether they're anti-inflammatories or bronchodilators, they're going to have a systemic response. So think about giving prednisone, think of giving solumedrol, powerful corticosteroids. They're going to have a systemic side effect, and we know that corticosteroids have some significant side effects. For every intervention, there's a correlating set of potential complications, and we need to know what those complications are, and that's what goes into the decision of what medication to give. Risk-benefit analysis. Inhalation of drugs allows that medication to go directly to the lungs, as opposed to systemically, throughout the body. Different types of vehicles for administering inhalation drugs. Meter dose inhaler, what you're familiar with. The patient will, excuse me, place it in their mouth or close to their mouth, and it's timed. So inhale, exhale, and as they're inhaling, breathing it in and holding it as long as they can. Meter dose inhalers work well when you have a patient that is able to time it, inhalation or exhalation. If not, if it's a pediatric patient and they're like pushing it away from you and you're trying to get it on inhalation, it's not going to work. Or an elderly patient that's confused and it's like, and they don't know when to give it. So in those situations where you have a meter dose inhaler and that patient can't time it, you're going to put this spacer on right here. A spacer allows you to press it, keep it up on the patient, nose and mouth, and then the patient can breathe it in and you don't have to worry about a timing issue. So spacer, meter dose inhaler. This is an example of a dry powdered inhaler, which might be like your Advair discus. The patient will put their mouth on here, as you can see this lady doing. There's a little handle here, and you'll click the handle, which is going to drop the powder into the reservoir here, and then the patient will breathe it in. And then when they're ready for the next dose, they'll click it and then breathe it in. So usually it's only one. One dispense each time. Ineffective airway clearance for asthma and impaired gas exchange. We talked about this earlier. Don't get those two confused. Ineffective airway clearance has to do with a bronchoconstriction, and it has to do with mucus, increase in thick viscous mucus. And that is different from impaired gas exchange, which is where it's preventing the oxygen and CO2 from reaching the alveoli and exchanging across the alveolar capillary membrane. The goals of therapy are going to, for asthmatics, is to maintain 80% or better of their personal best for the peak expiratory flow rate. Peak expiratory flow rate is a meter that the patient is going to use, and it does have a kind of like a mouthpiece on it for the patient, and the patient will breathe into it, and then it's going to have a dial. As they exhale into it, the dial is going to move up, and they're going to measure how far the dial goes based upon their expiration. So peak expiratory flow rate or peak expiratory flow meter, there's a measurement. So when they're first, breathing in to this, that they're going to, over a period of time, figure out which one of these breaths moves this dial the highest, and then they'll set the dial back to 0 and they'll blow it again. Whichever one is their greatest inhalation here. That's an eyeball, and this is the nose, and this is the mouth, and they're putting their mouth on there and they're blowing it. They're going to take that highest number, and that's considered to be their personal best. So as they're maintaining, and just look this up, those of you who have the slides, which all of you do, all you have to do is click on this. You want to minimize it so that you can see all of the slides listed, and then click on this, and it's going to take you to a video which shows you what the peak expiratory flow meter looks like. And it probably looks a little bit better than my picture here, though not as dramatic. And so the patient that has asthma is going to want to maintain 80% of the personal best. That's that 100% here. Their greatest exhalation effort that moved this dial the furthest. So we'll look at what that would look like for a patient. So again, that patient knows that they want to continue with their medications or avoidance exposure to allergens, so that when they do their peak expiratory flow rate, it's 80 to 100% of their personal best. When it gets below that, 50 to 79% of the personal best when they use their peak expiratory flow meter, that means that caution, yellow zone. So green light, yellow light, red light. Yellow zone means caution, something is probably triggering an asthmatic response. The red zone is when they use their peak expiratory flow meter, exhale into it, and it's less than 50% of that personal best. That's a serious problem, and they need to seek medical attention. Okay, since these patients have asthma and it's a chronic illness, the goal is going to be simply that we don't want these patients to have any interruption to a quality of life. So these patients should be able to carry on, and we should be able to manage the asthma so that there's no significant impact on what they do on a day-to-day basis. We want to try to do what we can to decrease the incidence of actual flare-ups or asthma exacerbations that the patient experiences. And most of all, we want to keep this patient out of the emergency room. And we should be able to do that with long-term medication, patient following their peak expiratory flow rate, and looking to manage at 80% or greater of their personal best. Okay, so COPD is a chronic obstructive pulmonary disease. And we mentioned that the number one killer of Americans was cardiovascular disease. We also said that the primary risk factors, top three, included cigarette smoking for the number one killer of Americans. Number two killer of Americans is cancer. The number one cancer killer in both men and women is lung cancer. The number one predisposing risk factor for lung cancer, cigarette smoking. Well, guess what? COPD in recent years has moved into the number three spot for it's the number three killer of Americans, chronic obstructive pulmonary disease. What do you think is the number one predisposing risk factor for COPD? Cigarette smoking. Exactly. So, we talk about access to healthcare, affordable healthcare. We know what to go after in order to drastically improve the overall health of Americans. It's obesity and cigarette smoking. So that's what I want to see lobbied for. Here we go. Third leading cause of death in the United States. Look at this, 24 million adults in the United States. Sobering statistic. More than 50% of the patients die within 10 years of being diagnosed. When do you think most of the patients with COPD from cigarette smoking are going to be diagnosed? Yeah, in their 50s, mid-50s, later 50s. That was the example with my sister that I gave you to earlier. So that means that if, let's say, on a high note, they're going to get diagnosed in the very latter part of their 50s, so 59 years of age, 50% of the patients are going to die by the time they reach 69. My sister died at the age of 61. And so why cigarette smoking? That is the only reason why she prematurely died. Two beautiful children and grandchildren that she left behind. Third leading cause of death in the United States. Where's all the outcry? There's a lot of outcry for other things in our political realm. Where's the outcry? And we're going to see some of the startling statistics for how many people are affected by cigarette smoking and die every year. COPD. It's an umbrella term, and it's an umbrella term for these two disorders, chronic bronchitis and emphysema, and we'll talk about them individually. Chronic bronchitis affects the bronchioles and the bronchi in the airways. It looks just like asthma. Its effect is the same as asthma. And so when you see some of these slides and you see the pharmacologic interventions, you say, geez, that looks just like asthma. Yeah, because the same thing is happening. Um, Remember that COPD is a chronic inflammatory response of the airways that is irreversible. Irreversible. So we're going to damage initially the bronchi and bronchioles predominantly from cigarette smoking, and that's going to trigger the inflammatory response. Prolonged exposure of anatomical structures to the inflammatory response is going to cause those structures to be remodeled. We've lost the integrity of the cells and the tissues, which is going to impact the efficiency of that organ to maintain its normal role and function. And ultimately, that's going to affect the system as well. So same thing that we saw with asthma, normal, healthy, bronchi, bronchiole here, bronchiole with a smooth muscle. Then we have the chronic inflammatory response that's triggered from cigarette smoking, a toxic, nauseous, cancerous gas. It's going to trigger bronchoconstriction. Smooth muscles are going to constrict. It's going to increase in sending vasculature, blood, and fluids to the area, and it's then going to also significantly increase mucus production. Not only is it going to increase mucus secretion, but there's going to be an increase in number of mucus secreting cells as well. That's a bad combination, and this is chronic. This is chronic and it's irreversible. And that's why we're going to see it's the number three killer of Americans. Emphysema, on the other hand, predominantly is going to impact the alveoli, where chronic bronchitis eventually is going to impact the bronchi and bronchioles. Emphysema is going to be the alveola. And that's where you're going to have your gas exchange. And so if you have destruction of alveola from exposure to prolonged chronic inflammatory response, you're going to eventually kill off the alveoli. You're going to so remodel them that they're not going to be able to participate in gas exchange. And remember what that happens, the more alveoli that are destroyed, because of COPD. These alveoli are no longer going to participate in gas exchange. What have we done? We've just increased the physiologic dead space, those anatomical structures that do not participate in gas exchange. Why? Because the patient is choosing to smoke. Hypoxemia is going to result. That certainly makes sense. The more alveoli that are destroyed, the less oxygen that's going to get into the vasculature, the more CO2 that's going to get trapped in the body and not be able to be released from the alveoli on exhalation. So not only do we have hypoxemia, but we're also going to have chronically high CO2 levels as well. The kind of a late manifestation of COPD is cor pulmonale. Good thing to know. Cor pulmonale is right-sided heart failure. Remember we said that the heart is going to, right ventricle is going to pump blood to the lungs and through the pulmonary artery. The vasculature in the lungs are very sensitive to hypoxemia. And the arterial vasculature, in response to a perceived hypoxemia, they're going to constrict. So these vasculature are going to constrict. So now we have the poor little right ventricle that is pumping the same volume of blood to the lungs, to diseased lungs through constricted arterial vessels, and eventually, the right sided of the heart is going to enlarge, and then it's going to weaken, and then we're going to have right-sided heart failure. So cor pulmonale is a late manifestation of right ventricular failure as a specific result of pulmonary hypertension. The pulmonary arteries are constricted, and the heart's going to beat right ventricle much smaller than the left ventricle, and we're going to have right-sided heart failure, cor pulmonale. So make sure that you recognize that. I mentioned when we were talking about tuberculosis that on chest X-ray, what you're going to see, remember, are those air-filled cavities. Those air-filled cavities on the chest X-ray, otherwise known as bulla, represented this massive destruction in alveoli. Now, in theory, what we have, instead of all these individual nice grape-like clusters of alveoli, they're all destroyed, and we have one giant alveoli that it does not participate in gas exchange, so air gets in and it gets trapped. The same thing is what is going to happen with emphysema. Eventually, there's going to be such a massive destruction of alveoli that on X-ray you're going to see these huge air-filled cavities, or bulla. And that's why I said on a chest X-ray, for a patient that has tuberculosis, even though they have a positive PPD and the patient also has air-filled cavities, that's still not a definitive diagnosis, because guess what? You can see the same thing on X-ray for a patient that has COPD, in particular emphysema. Very sad. Okay, primary risk factor, far and away the number one risk factor for the development of COPD, the third leading cause of death in the United States, is cigarette smoking. There's absolutely nothing positive about cigarette smoking. I would be very happy to see it eradicated from the public. So cigarette smoking worldwide, the number one cause of COPD. What does smoking exactly do? In addition to the fact that it destroys your alveoli and it causes destruction of the bronchi and bronchioles, it increases mucus production. That toxic, noxious gas stimulates the inflammatory response, which increases mucus production. Over a period of time, it also stimulates an increase in mucus-producing cells. So now you have an increase in mucus-producing cells that are overproducing mucus. And that's why the patients, when they wake up in the morning, they have that horrible, nasty, wet-sounding cough, because overnight, as they've lied supine, all that mucus just builds up, and they're trying to get it out. And a lot of times they're not successful in getting it out. Why? Because they've also burnt off or paralyzed their cilia. So every time a patient lights up a cigarette, the cilia, which is what lines the respiratory tract, is going to push the mucus up. Beats like 1,000 little hair-like structures that pump in the airway, and is going to move the mucus up so that the patient can cough and it can expectorate. Well, with cigarette smoking, it paralyzes the cilia. All that mucus is now building up. The cilia is paralyzed, and eventually, over time, it kills off the cilia. So great, now we have that warm, dark, moist environment in the respiratory tract, significant increase in mucus production, what a medium for bacterial growth. That's exactly what happens. These patients in that 10 years, they're going to spend a lot of time in and out of the hospital with pneumonia superimposed upon already diseased lungs from COPD. If that wasn't enough, the cigarette smoking, the gas is tasteless, it's odorless, and it carries carbon monoxide. We mentioned previously that there are 4 receptor sites on the hemoglobin of a red blood cell for carrying oxygen. Well, unfortunately, carbon monoxide has a higher affinity to the receptor sites than oxygen does. So it's going to bump oxygen away from the receptor sites. And now all of these receptor sites, which should be carrying oxygen, are now carrying carbon monoxide. And that's why that patient is going to be short of breath and dyspneic when they walk out to get their mail, when they walk up one flight of steps, when they take their dog from a walk. And the more actual, carriers of carbon monoxide, and the more destruction overall of the alveoli, the patient's eventually going to wake up and they're dyspneic and tired. They're going to be dyspneic and tired all day long, and they're going to go to bed dyspneic and tired. Why? They chose cigarette smoking, which in earlier generations we didn't know that. The tobacco companies were hiding it from us. The deleterious effects of cigarette smoking, including lung disease, cancers, and cardiovascular disease. They were hiding that information that they knew and faced a massive lawsuit. Now we know. Now there's no excuse. And why it's still being distributed, there's really only one reason, and that's because of the monetary value in our capitalistic economy. Okay, Um, 2015 facts. Yeah, look at this. It is estimated that 480,000 Americans die each year as a result of cigarette smoking. $480,000. Where is the public outcry? Where is the political outcry? We see smaller numbers, that are experiencing unfortunate deaths, and there's this huge public outcry and a call for banning. But what about this? 480,000 Americans die every year. And there's little to no political outcry. There's little to no public outcry. So healthcare workers, we need to be the ones that sound the call. We need to be the ones that continually sound the alarm. Half of all people who are smoke are going to die from smoking-related diseases. Not surprising. What's in that tobacco? That tasteless, odorless, noxious gas that people are infusing into their lungs, inhaling into their lungs. There's over 7,000 chemicals, including 69 chemicals that are carcinogenic and known to cause cancer. Where's the outcry? All right, the following slides are a pictorial representation of the effects of smoking on life. It just happens to be that this individual represented is my sister. Um, and Here's my sister at age 33. Did start smoking in her teenage years. Here's my sister 22 years later at age 55 with my other sister. And they are celebrating the fact that my sister just had to move into a skilled nursing facility because of her COPD at age 55. Here she is at age 59, 4 years later. And she died at age 61. Why? From cigarette smoking, which resulted in COPD, which is the #3 killer of Americans. There are some risk factors to COPD, certainly aging. The longer the patient smokes, the higher the risk of developing COPD. And just naturally, as the older a patient gets, they're going to have some changes to their respiratory structure. And again, if I don't spend a lot of time on a slide, it doesn't mean that it's important. It's good to know. Might not necessarily be a need to know basis at this point. So COPD, mucus hypersecretion, we're going to see, a dysfunction of the cilia. They're going to be paralyzed every time a patient lights up a cigarette for 30 minutes or more, and eventually it's just going to kill off the cilia. Hyperinflation of lungs. When we have the chronic inflammatory response and we're destroying alveoli, what happens in that inflammatory response is it destroys the structural integrity of the individual alveoli. The inflammatory response is going to damage the structural integrity of the semi-permeable alveolar capillary membrane. Oxygen is going to get into the alveoli, but it's not going to be able to cross the semi-permeable membrane because it structurally has been impaired. So likewise, the capillaries that are bringing CO2 back to the alveoli, CO2 is going to be increased and built up in the body. And so you have air coming in and filling up the alveoli, but that air can't diffuse across the semi-permeable membrane, so the air gets trapped. Eventually, that's going to cause a hyperinflation of the alveoli. They'll become significantly distended, and when it's a hyperinflation, the more distension, the less oxygen and CO2 they're actually going to exhale. So you're going to have a significant increase, in air trapping, which causes a hyperinflation of the lungs. In fact, the lungs eventually are going to become so distended that you're going to have what's called barrel chest. The patient's chest, anterior posterior diameter is going to significantly increase, and it's going to increase and lock there permanently from a hyperinflammatory response, which causes hyperinflation of the lungs. Gas exchange abnormalities we talk about. There's no gas exchange happening through damaged alveolar membranes. You're going to have your decrease in oxygen levels, hypoxemia, and you're going to have your increased levels of CO2 levels. Often emphysema and chronic bronchitis coexist. Good question. And I always wanted to drive behind those patients, and people in their cars, and they've got those bumper stickers that say coexist, and I always wondered what that meant. Now we might know it. It's emphysema and chronic bronchitis, can be separate and individual, or they can coexist. Just kidding, of course. All right. Sometimes the symptoms develop slowly. Um, How do we diagnose a patient that has COPD? Well, you take a history. That's the most important thing. You smoke? Yes. How many packs a day? Well, 1.5 to 2 packs a day. How long? 20 years. Okay. Do you have dyspnea on exertion? Yes. Do you have a productive cough? Yes. That doesn't seem to go away. Guess what? You've just been diagnosed with COPD. We did say that pulmonary function tests, PFTs, pulmonary function tests, which are typically performed by respiratory therapists, they're going to measure the forced expiratory volume over 1 second and forced vital capacity. Again, those are both exhalation tests on exhalation. Inhale, 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 and blow, 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 blow. So that's going to measure the exhalation and the force of exhalation and just how much air is going to, the patient is going to move on exhalation. So these are the two, the forced expiratory volume over one second, that's like, and blow, and how much are they able to blow in that first second, and then the forced, vital capacity is the second one. Remember we said that the forced expiratory volume over 1 second, forced vital capacity, they're good not only for diagnosing a patient has COPD, they're also good for helping us discern whether or not the disease is progressing in an individual, but they also can be used to see if whether or not the medications and the pharmacologic interventions are actually helping and improving the patient's ventilations. So be aware of that and look for that if there's a question related to, what diagnostic procedures will help to determine if the patient is responding positively to the pharmacologic agents. It's not incentive spirometry. It's not your peak expiratory flow meter. It's these two right here. And ABG, we talked about where you might see a patient that has uncompensated respiratory acidosis and with COPD. Dyspnea, we talked about that, and initially it's just with exertion. Eventually they're going to wake up dyspneic and go to bed dyspneic. They'll see chest breathing. The patient is able to get that air in. It's an active process, remember, and they can use accessory muscles to get in, but it's a passive process, so they have a hard time getting air out because you're going to have air trapping and collapse of just the alveoli are going to be hyperinflated and they're just going to trap air and there's going to be no diffusion of the air. Chronic fatigue, the patient's going to spend most of their energy just trying to breathe. And malnourishment. In fact, 1 out of every 3 patients that has COPD is going to be malnourished. So when you look at fatigue and you look at malnourishment, what would be good, nursing diagnosis down the road. So you might have, impaired gas exchange. You might have ineffective airway clearance, imbalanced nutrition, less than body requirements. Again, an activity intolerance. Wheezes on exhalation, just like with asthma. Decreased breath sounds, the more alveoli that are destroyed, the less air movement you're going to hear on auscultation, so you can have decreased to absent breath sounds in some areas. Prolonged expiratory phase is going to be longer than the inspiratory. The anterior posterior diameter is going to increase when you have hyperinflation of the lungs from hyperinflation of the alveoli. Bluish to bluish and red skin tinged color. So bluish is from cyanosis. This is a one I want you to know here. Polycythemia. Increased cythemia in blood cells. So in polycythemia, the body is going to increase production of red blood cells. Why does it do that? Well, after chronic hypoxemia, it's tried everything it knows to do, and then the body is eventually going to say, well, just maybe there's not enough red blood cells to carry oxygen, so it's going to stimulate the bone marrow to carry additional oxygen. But the problem is not insufficient red blood cells. The problem is that we have destroyed alveoli. So now the body has increased production of red blood cells, and the blood becomes a little more viscous at that point, and that patient will have kind of that reddish hue or red tinge to it, and that's called polycythemia. It's a clinical compensatory mechanism of the body to try to increase amount of oxygen circulating by increasing red blood cell production. Good to know. Cor pulmonale, we talked about that. Complications, which is your right-sided heart failure, specifically a result of pulmonary arterial hypertension. Respiratory failure, sometimes it's going to cause your peptic ulcers. Don't really need to know about that. Depression, anxiety, I guess so. Forget about Maslow's hierarchy and self-actualization in your latter years of life. You're not going to reach those. And looking back, and I'm sure that there is the potential for some remorse related to, gosh, I threw my life away with cigarette smoking and anxiety, because it's a progressive disorder. And these are the barrel chest that we talked about. Because of the hyperinflation of the lungs, it's going to expand the chest wall, and eventually the chest wall is going to be permanently expanded. That's called a barrel chest, where you have an increase in your anterior posterior diameter, and you learn that in your health assessment. Right-sided heart failure, we've talked about this several times. Direct result of pulmonary hypertension. Why? Because the pulmonary arterial vasculature constrict in response to hypoxemia. Okie doke. Exacerbations, this would be when your patient is going to experience frequent hospitalizations. Remember that they're going to have increase in mucus production, decrease in cilia activity. You have a lot of mucus secretions that are building up in the lower airway. No way of getting them out efficiently. Warm, dark, moist environment, great medium for bacterial growth. These patients are going to spend a lot of time in and out of the hospital with pneumonias that they develop already superimposed upon diseased lungs from COPD. And that happened again in my sister's situation. Okay, so what are we going to do? Let's the best of our ability. Let's slow down the progression of the disease, and let's try to improve the overall quality of life. Reducing mortality, the best way to reduce mortality is going to be to inhibiting early on the patient's use of cigarettes. So what do we do as far as treatment? Sounds like I wrote this, but I didn't. Cessation of smoking in all stages of COPD is the single most effective and cost-effective intervention to reduce the risk of developing COPD and stop the progression of the disease. Remember, it is a chronic disorder of the airways that is not reversible. It's a progressive disease. So let's decrease dyspnea with hypoxia, increase in your forced expiratory volume over 1 second, or you're going to use that for bronchodilator therapy, albuterols, and your long-term maintenance medications, Ceravents. No drug modifies the decline of lung function in COPD. It's an irreversible progressive disease. No drug is going to modify the decline of function in COPD, which is why 50% of patients die within 10 years of the diagnosis. These are the exact same medications that we previously saw. Perhaps with the exception of Advair discus, I might not have had that on there. These are the patients, because of the bronchoconstriction that they're going to experience, not from an allergen, but from a response to cigarette, the toxic noxious gas that they're going to be exposing their airways to. It's going to cause that bronchoconstriction, increase in mucus production. So bronchodilators, there we go. Beta adrenergic agonists, anticholinergics, methylxanthines, theophylline and aminophylline. Good to know. This slide is good to know. And whether we were, administering the medications for COPD or asthma, it's good to know what are bronchodilators versus what are good for anti-inflammatories. There are two medications I want you to know about that actually have both pharmacologic actions of anti-inflammatory as well as bronchodilation properties. Those two are the Advair discus and leukotrienes. Leukotriene modifier medications have the pharmacologic actions of both bronchodilation as well as anti-inflammatory. Advair discus, leukotriene modifiers. Good thing to know. Okie doke. Corticoids therapy. So on the other slide, we were talking about bronchodilators. Here we're talking about anti-inflammatories. Flovin and inhaled corticosteroid therapy for to help to decrease the inflammatory response. Inhaled versus systemic is always preferred. Oxygen therapy, good to know. Oxygen therapy is important for slowing down the progression of the patient's COPD, improving the quality of life, and improving overall longevity of life for our patient, and also slowing down the patient from developing cor pulmonale. So oxygen, when used appropriately, is going to slow down the progression of the disease. It's going to increase the quality of life, and it's also going to help prolong cor pulmonale. And same thing here. So good slide to know. Good slide to know. Well, let's look. So how does that work with cor pulmonale? We said that the pulmonary arterial vasculature, when it determines that there's a decrease in circulating oxygen, they're going to constrict, which is hopefully going to get blood supply there to the lungs more quickly to oxygenate the lungs. So if we give our patient oxygen, that's going to decrease the incidence, hopefully, of hypoxemia, which is going to decrease the pulmonary arteries from constricting, which is going to decrease the workload on the right ventricle, which is going to prolong right-sided heart failure. Not in all situations does the patient have right-sided heart failure. Sometimes they don't live long enough to have right-sided heart failure. Ineffective airway clearance, impaired gas exchange, risk for infection, difficulty sleeping, imbalanced nutrition, activity intolerance. All of these on this slide are good to know. Abstain from smoking. Yes. I will say that not all COPD is caused from cigarette smoking. The one slide said 80 to 90%. I think that's conservative. I think it's higher than that. I did have a student that raised her hand in class and said, my mom has COPD and she never smoked a day in her life. My next immediate question was, what was your mom's occupation? And she happened to say, her mom was a hairdresser. So exposure over all those years to the chemicals that hairdressers use caused her mom to develop COPD. And I thought that was very interesting. Sad, certainly, and interesting. Okie doke. Oxygen therapy, we talked about. Cluster your activities because of activity intolerance for these patients becoming quickly dyspneic, quickly hypoxic, and also just very fatigued. The final thing we're going to talk about is acute respiratory distress syndrome. When I was early on in my nursing career, working in the emergency room, we would have something that would be called adult respiratory distress syndrome, ARDS, adult respiratory distress syndrome. It has now since the name been changed from adult respiratory distress to acute respiratory distress. And just barely going to touch on mechanical ventilation, barely, as I say, because you're going to learn about mechanical ventilation in 202. So let me just explain what ARDS is, and you can use these slides as a complement or supplement or reminder of what we talked about. What happens in acute respiratory distress syndrome is that the patient is going to experience some significant insult. some significant trauma, motor vehicle accident, multiple trauma, breathing in a very toxic poisonous gas. Patient might have a dead gut, ischemic bowel or dead gut. But the number one cause of insult to the patient, which triggers ARDS, is sepsis. And we've talked a lot about sepsis in GI, and we're going to learn a lot about it when you progress in 201 and 202. So let's say that the patient experiences sepsis. In certain individuals, the sepsis is going to trigger this respiratory distress syndrome. Acute respiratory distress syndrome. Syndrome, S, is just as a accumulation of signs and symptoms. It's not a disease. It's a syndrome is an accumulation of signs and symptoms, clinical manifestations. So what happens in ARDS is that ARDS is secondary to this major insult or trauma from sepsis or something that they've breathed in or ischemic bowel. That's going to trigger what we call the systemic inflammatory response. SIRS, and look for that when you see your electronic health records. You're going to see that showing up. The systemic inflammatory response syndrome, again, syndrome is a manifestation of signs and symptoms. What happens as a result of that major trauma, that major insult to the body, is it triggers an inflammatory response that is not just specifically directed to where the area of the insult was, but throughout the body. One of the areas in this systemic inflammatory response that is significantly affected are the alveoli. The inflammatory response hits the alveoli hard. When it hits the alveoli, that inflammatory response again is going to cause a distension, a hyperinflation, because it's going to cause some air trapping. The other thing that inflammatory response does is that, remember that we said that the alveoli manufacture and secrete surfactant, which keeps the alveoli from collapsing. Well, the hyperinflammatory response from SIRS is going to inhibit production and secretion of surfactant, and that's going to cause the alveoli to collapse. Massive collapse of the alveoli. And if that wasn't bad enough, the inflammatory response in SIRS is going to cause an increase in the permeability of the alveolar capillary membrane. So when you have an increase in the permeability of this membrane, not only is oxygen and CO2 going to diffuse across, but it actually is going to allow for the leakage of vasculature across the membrane. So the gas and the CO2 and the O2 can initially participate in gas exchange, but because the semi-permeability has been increased, the vasculature from the capillaries is going to leak, and that's going to cause an increase in fluid accumulation in the alveoli. So the increase in accumulation of fluid in the alveoli combined with a decrease in surfactant is going to significantly impair gas exchange, and especially when the alveoli collapse on themselves, that massive atelectasis. It looks like a whiteout on a chest x-ray. Okie doke. So the assessment, symptoms are going to appear 24 to 48 hours after that initial injury or insult, whether that's trauma, breathing out toxic gas, gut ischemia, or sepsis, which is the number one cause. Patient could have perfectly healthy lungs, nothing's wrong with their lungs. The insult or even the sepsis wasn't affecting the lungs, or didn't start out as a pneumonia, for example, but now all of a sudden they're starting to have respiratory symptoms that are coming on rapidly. The hallmark sign for a patient that has ARDS is that these patients, as they begin to get hypoxic, they begin to have dyspnea and tachypnea. That we're going to put oxygen on. We're going to put this patient on O2 per nasal cannula to start with, 2 to 3 liters. Well, guess what? There's absolutely no improvement in the oxygen saturation. Oxygen saturations have gone from initially 97% to 95% to 94%. We put oxygen on the patient. no change. In fact, the patient's oxygen may be even decreasing, 93%, 92%. Well, we'll increase that nasal cannula up, to 5 liters, no change. 10 liters, no change. We'll put the patient on a face mask, no change. And the reason is it doesn't matter how much or the route of oxygen that we're giving this patient. If the alveoli are collapsed, if the alveoli are filling up with fluid, there's no gas exchange that's going to happen. So these patients become significantly hypoxic, and they need to be intubated and they need mechanical ventilation. What we're looking at, which is interesting, when we have a patient that is developing pulmonary edema, abnormal accumulation of fluid in the alveoli or the lung tissue. We had said in a previous slide that the predominant cause of pulmonary edema is heart failure. And so in a lot of times with heart failure, you're going to see an increase in the size of the heart, left ventricular hypertrophy, cardiomegaly, as an example. When we have ARDS, gosh, we're seeing pulmonary edema, but we have no heart compromise. And so in that situation, what we have is a non-cardiogenic pulmonary edema, non-cardiogenic. Remember, cardiogenic pulmonary edema, it means that the genesis or the cause of the heart failure, which triggered pulmonary edema, is heart failure. When we have a healthy heart in ARDS, but we have pulmonary edema, it's a non-cardiogenic pulmonary edema. High percentage of these patients are going to die. Previous slide I think said upwards of 40% are going to die, and here's why. This is what the chest X-ray looks like. This is the massive whiteout caused from massive collapse of the alveoli or atelectasis. There's no gas exchange or minimal gas exchange that's happening in these lungs. And so that's the problem. Well, what determines what patients die and what patients live? Well, we try our best to keep these patients alive. We, as long as we can, treat the underlying cause, intubate the patient, give them high pressures, inhalation and exhalation, airway pressure. But eventually, what is going to determine whether these patients live or not is those patients whose body shuts down the systemic inflammatory response system are going to live, and those who go on and the body doesn't shut it down, have a very high mortality rate. Okie doke. So treatment, that we said that because of the increased inflammatory response and then the fluid buildup in the lungs, the decreased surfactant. So we're going to give the patient surfactant therapy down the endotracheal tube. High pressures, intubate these patients, mechanical ventilation. The problem is what we have to give these patients such high pressures. We're trying to open up closed alveoli that are collapsed. So we need high pressures not only to open up the alveoli, but to keep them open long enough for exchange of gases. Unfortunately, those high pressures oftentimes are going to result in us causing a pneumothorax on our patient, where we're going to blow a lung or two, and that requires putting in chest tubes to remove the air from the pleural space. So again, we're trying to keep these patients alive as long as we can. Treat the cause. If it's sepsis, you've got your antibiotics. Gosh, we have to be careful with fluid replacement. We can't just pump fluids in the patient because they're developing pulmonary edema. So very, very difficult patients to manage, which is why they have a significant mortality rate. Gosh, I have really enjoyed being with you during this trilogy of videos on the respiratory system and the management of patients with respiratory disorders. So I hope that you have learned. Feel free to watch this video as many times as you like. I've tried to point out the important things that might be presented in a test if you ever take nursing tests. Those slides that I might not have spent a lot of time on, or maybe even bullet points within the slides that I didn't talk a whole lot on. They're probably a high probability that they might not be put in a question format for a test. But of course, I can't tell you that. But that's what I can give you as far as guidelines for my tests. When you talk about GI and respiratory, I like you to study the slides. Study the slides and the content that I presented in the slides. Those are the most important things. Everything that you'll see on the test has been presented in the slides. I take all this information that's important to know about GI and respiratory, and I say what is important, a need-to-know basis. I try to teach that as best I can, and I will test you on that material that I felt that is most important for you to know at this juncture of your education. So be strong, be healthy, stay healthy, and thanks for joining.